Hi, everyone, and welcome to today's webinar, Clot-busting, a multifaceted approach to VTE prevention. This is Mackenzie Bean, Managing Editor with Becker's Hospital Review. On behalf of Becker's, thank you all for joining us today. Before we begin, I'd like to walk through a few quick housekeeping instructions. We'll kick off today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box that you see on your screen. We'll also have a series of polling questions during today's webinar. You can submit the answer that best applies to you directly on your screen in the slides box, and thank you in advance for your participation there. Today's session is being recorded and will be available after the event. You can use the same link that you used to log into today's webinar to access that recording. If at any time you don't see your slides moving or have trouble with the audio, please try refreshing your browser. You can also submit any technical questions into the Q&A box, as we are also here to help. With that, it is my pleasure to introduce today's speaker, Dr. Amy Campbell, who is a quality nurse specialist at Cardinal Health. Dr. Campbell, thank you so much for being here today. I'll now turn the floor over to you to get us started.
Wonderful. Thank you so much for this opportunity to talk about something I really enjoy, working with VTEs, preventing them, working with my team and my providers, and throughout the system I'm in Eastern North Carolina with Vidant Health. So the first thing I'd like to do is just tell you a little bit about me. I know there's over 500 people that are on the call and registered today, and it's kind of hard to make that bond. Usually when I'm in front of you, you would get to see me. We would talk a little bit maybe before I presented. And I really believe in building psychological safety and being a relational leader. So the first thing I'm going to do is just tell you a little bit about me. As I go around the slides, the first one here, you see kids, and these are my two boys. I'm a single mom. I would say that was probably one of my proudest accomplishments. My son Grant is 17. My oldest Riley is 19. He's autistic, although he would tell you at times I'm the one with special needs. If you're like, how do I get my teenagers to wear matching pajamas? You get them a PS5. Because when they opened that, they were very excited, and I knew I was getting the pajama pictures. So I've tortured them with these pajamas for years, and I plan to show them to all their dates when they come over. The next slide I want to show you is at the top, and this is Dr. Holly Way, Dr. Elaine Scott, Dr. Diana Lane, and I shared this poster presentation with you because it was kind of, sometimes we get so wrapped up in being perfect with our quality initiatives, and it really is not about being perfect. It's about progression and just going with it. And when I showed up for this conference and saw how small my poster was compared to everyone else's, when you see this, it should have taken up the whole whiteboard. I almost didn't present it. And I actually got first place, and even when the judges said it was small but mighty. But it just shows that sometimes you just got to fake it till you make it and go with it. The next slide is two of my colleagues. That's Kimberly Carter and Charlene Turnage. And this is right during the pandemic. We were out rounding. I can't tell you enough for my friends in quality to be out there on the front lines, be rounding. Really, in lean, we call it the Gemba walk, but really be walking the walk and seeing what's going on. It's very hard to know what the pool feels like and the temperature of the water if you're sitting outside. The other slide is my feet. That's me hiking. I love to hike. I love to camp. Love to be outside. I'm definitely a girly girl, but I love all those things. I love Disney World. That's down at the bottom. I would go every couple months if I could afford it. And Disney has a great quality program, so that might be my retirement plan. I love sharing this glamour shot of me in the beginning, in the middle of the screen. This actually happened. I got an award, and I've been to East Carolina University now. I have 3 degrees from there, so I'm a 3-time pirate. And they need a picture of me for a grant, and I looked like I did at the top, no makeup, hair pulled up. I ran across the street, fluffed my hair out, got some lipstick from the Dollar Tree and pearls, because that is normally not my shade of pink. But, you know, the picture turned out pretty good, and we can all have a good laugh. The other picture of me running, I'm an endurance athlete. I like to participate in ultramarathons. I think they're so much fun. I've been trying for almost 4 years to hit my 100K, which is 63 miles. And this particular race, I finally did it. I actually got 64 miles. And these are two of my friends that ran it with me. And then lastly, there's actually a brick at East Carolina University with my name on it. If you come to Greenville, I'd love to take you out. I'll show you my brick, and you're going to be like, wow, Amy, what did you do? Is this because of your VTE research, your sepsis initiatives? Actually, no. I graduated during the pandemic, and I think my parents felt sorry for me because I didn't get a graduation or a party, so they bought a brick with my name on it. So now we are fast friends. I hope you will feel comfortable with me. You'll feel comfortable asking questions, because as you do your own committees and your own work, you want to create that psychological safety where anyone can ask anything. So let's get to talking about VTEs. First thing I'm going to do is go over the objectives. I promise this is the last time I'll read to you. Discover how multidisciplinary leader collaboration and VTE committee structure impact prevention efforts. Learn to transform your facility and patient case data into rationale for continued improvement. Determine approaches from this facility that can be replicated in your own, and that's really important about today. I want you to take, not all these things are going to work for you, but I hope you will find some pearls and some things you can take back, and you can really transcend it within your organization and disseminate it. We're going to talk about order sets, patient education, how to do protocols, tracking true patient compliance, and building support along the way with our Clotbusters, which none of the things I could have done could have happened without my Clotbusters. So a little bit of background, and this actually comes from the CHEST guidelines and ACOG, which is the American Congress of Obstetricians and Gynecologists. But we talk about a PE versus a DVT. Now, I know a lot of you on the line know this, but just a little quick background. What's going to happen in a DVT is you're going to hit Virchow's triad. You're going to have stasis, you're going to have endothelial injury, or you're going to have hypercoagulability. And because you either have one or all three of those things, you're going to form a clot in your leg. That's my DVT. You're going to start developing pain in your leg. Then that's, if we don't catch it and get you on some type of anticoagulation, it's going to travel up to your lungs. It's going to block the pulmonary artery. You're not going to be able to exchange oxygen. You're not going to be able to breathe. And many times, unfortunately, you can code and die. And these are those really sad stories. You hear about someone had an elective procedure. They went home after the procedure, and they threw a clot, is kind of our layman's term for it. And then they end up having that happen to them, and it's so tragic. Within the United States, you see the number. We have 100 to 300,000 deaths each year, 1 in 1,000 diagnosed. This is a very expensive, preventable thing for our organization. $15.5 billion a year, 275 deaths from blood clots, and 1 in 4 people worldwide. So as you see this, you understand why we need to understand where the VTEs come from, how to prevent them, and how to do a better job for our patients. So I got to tell you a little bit about me and my story. When this began, it was in November of 2019. I'm running my regular reports. I'm looking at our VT numbers, and all of a sudden in 1 month, we had tripled our numbers of PEs and DVTs. Most of it was at Vidant Medical Center, which is our academic medical center, but we also were having them in our regional hospitals. And a lot of times you hear in quality improvement, you know, let's not knee-jerk. Well, I'll tell you, I was on the ceiling. I was much further than knee-jerking. And from there, we had to pause, say, what are we going to do about this? We formed a multifaceted approach, and I'm going to tell you all about the stars in this approach. And then we were able to decrease our VTEs. And when we decreased our VTEs, we actually had a 69% reduction, which is really impressive. And just, I cannot say enough. It wasn't just me. It was all the wonderful people I was working with. But I want to tell you a little bit about my organization. I'm a quality nurse specialist at Vidant Health. The main hospital I'm at is at the Vidant Medical Center. And then I also work with our region, which is 9 hospitals within Eastern North Carolina. Now, you probably have already figured out I'm from Eastern North Carolina by my accent. It is real. And so just a few things that go on here every day. We have over 100 physician practices. We have 14,000 team members. Things about our system, our admissions in a year are around 64,000. Outpatient visits are around 350,000. Emergency room visits are around 260,000. We do about 50,000 surgeries. We have about almost 6,000 babies here, and we have our operating revenue, our net operating revenue is around $1.8 million. So just some things, 1.8 billion. So just for things to you to think about, because sometimes, and we learned about this with our latest Vizient presentation about our stages of grief, we often, when we present data and we look at data, we think, well, our hospital's too small, our hospital's too big, our patients are too sick, that doesn't affect us. In the stages of grief, that's actually bargaining. So we want to get down to acceptance of going, you know what, maybe we could do better. When I talk about that number that tripled in November 2019, there were plenty of patients in there we had done everything right for, and we call that just a flawed metric. And so, yes, those patients, probably not a lot we could have learned from them. But then there were other patients where we realized, you know what, as a system, and we're going to talk a lot about systems approaches, we could have done better. So one of the first things, I like to storytell, so we're going to start off with a really simple case study. And you see Mr. Smith here, he's sleeping. You know these patients, my nurses, bedside nurses, they're on the line. These look so innocent, and they'll be the ones that'll cause you the most trouble. But Mr. Smith is a 76-year-old man with a knee replacement. Then post-op day 2, he develops a PE. And I think this population, or when you see someone who's coming for elective surgery, they're doing so well, they're eating, they're drinking, they're moving, and then they get this complication, it's devastating. Because now they're going to have, usually they're going to end up being in the ICU. We've now got to they've extended their stay, we've extended their costs, and when they're in the ICU, now if they've been ventilated, we have even more complications that could happen for them. So when we think about this and you say, how could we have prevented this? He's a 76-year-old with a knee replacement. Anytime you have someone 65 or older, they're already at risk. Now you're doing something that affects their mobility. Remember when I talked about Virchow's triad? Stasis, mobility, no movement. So when you first come in, you know he's at risk. He's a surgical patient. So we want to make sure we order everything for him up front, that we have the VTE prophylaxis ordered for him and it is given before surgery. Sometimes because of everything going on with patients, we'll give the Lovenox after surgery. If we really want the Lovenox or heparin to do what we want it to do, we want to make sure we're giving them the prophylaxis they need. The other thing we want to talk about is, let's say for some reason he had a bleeding disorder or there was a reason he was not a candidate for the chemical prophylaxis, which is what I'm referring to in the medication. We want to absolutely make sure we're doing the mechanical prophylaxis, which is what we're going to talk about with the STDs later on. And that's really, how can we prevent VTEs is being proactive, doing our risk stratification, recognizing, who is at risk, using our risk assessment tools, doing the protocols, having a standardized approach, having order sets. When this patient comes in, or any patient within my organization that's having a surgery, they're going to all get the same prophylaxis. And when should a medication be held? Like I said earlier, if you have some type of bleeding disorder, obviously that is what we call a balancing measure. We definitely don't want to give the Lovenox and then cause another complication during the surgery, and then they have to give blood products, or worse, have a bad outcome where they bled out. But a lot of times there are actually screening and things the physicians can look at where you kind of look at pros versus cons. If I give this medication to them, yes, they're at risk for bleeding, but what is worse, that they have the bleeding or they have the clot, and that's a provider's decision on what they need to do. What I want to tell you about this kind of patient, or when you think about medications being held, is absolutely call the question of, does this medication need to be held, and when can we restart it? A lot of times, because we're all human, the patient moves, they go to a different floor, things happen, and that Lovenox or that heparin falls off the MAR, and that causes major problems for us, because then we go days without chemical prophylaxis. And absolutely the best thing you can do for these patients to prevent a clot is giving them that chemical prophylaxis, that Lovenox, that heparin that's going to break down the clot before it forms. So now I want to take a moment and take about 45 seconds. I'm going to grab a little bit of water, and I want to hear from you. Does your facility have a VTE committee or PE response team? And I'll give another about 10 seconds so everybody has opportunity. Okay, very interesting. We're split. Great. Well, hopefully those of you who do not have a VTE or a PE response team, I'm going to give you some little pearls and secrets where you may be able to tag on to another committee, especially right now when we have a workforce that is very overworked, very tired. COVID's worn people out. Being on a committee or doing another project may not seem like it's in their wheelhouse or even in their energy or wingspan. That there are different ways you can be able to form a committee that can be very, very effective without having the traditional committee. So, one of the things next we're going to talk about is how do we do this? Amy, if there's a formula, what's the formula? This is it. It's really similar to Data-Benia, which is structure plus process equals outcomes. And you want to get the right people, the right data, and the right results. And this just isn't for VTE. This is absolutely for any of our quality initiatives that we're working on. When I talk about VTE, and this is what I was alluding to just a second ago, when you think about your VTE task force, it doesn't always have to be that traditional task force. Within our organization, what I did in the very beginning when we had that huge jump is I went and formed a focus group. I pulled nurses from different floors, from different experience levels, and I asked them, what are your VTE barriers? Why are we not doing the prophylaxis? Why are we not wearing the STDs? Why are we not giving the medication? And I was able to get a lot of great data from there. From there, I formed a really wonderful dyad with a physician champion, and that was Dr. James Manning, and he has been absolutely phenomenal to work with. I've also had the opportunity to work with Dr. Mattapati, who is a medical intensive care doctor, and I've been on his pulmonary embolus response team, a research team, and that's been a great way to gather data and work from another lens. The other thing I've done is worked within, and this is again tagging onto that committee, a lot of my VTE work has been in the patient safety indicator group, which is a surgeon group where they look at all of our patient safety indicators through AHRQ. And with that, we go down, we look at each one of them, and we say, is this a flawed metric? Is this an area of opportunity, or does this even need to go to peer review? And peer review is where you're going to have a provider review that provider's performance to see did they do the right thing or not, and it is tracked to see if there is a trend. So having that, you can have a traditional group that gets together. Now, these groups don't have to be hard. If you're like, well, you know, Amy, I really want to form a group, I'm not sure how to do it, get you a strong physician champion. Get some really great bedside nurses, forward-facing staff. They're doing this every day that enjoy this work. Get a quality nurse specialist in there that can help micromanage. That's the only time I'll use the M word. But they can really project manage for you well. They can bring the data. Have a clinical expert that could be your quality person, or that might be someone completely different. And then have a nursing exec or a leader there to help push through the barriers for you. These are not the people you hang out with necessarily on the weekends, but they are the people that are going to help get things done. I think that's been the joy of working with my physician champion. He's able to push through barriers that I cannot get through. So you really want to have the right people there. Then when you think about your data, when you have this group together, you want it to be meaningful, you want it to be exciting, everyone wants to be there, and you want it to be short. You want a 20, 30-minute meeting at the most. You want a strong aim, your smart aim. You know, I want to decrease VTEs on Unit X by May 30th, 2022. And then you want to think about what is the data I want to look at. And you want process measures for your outcome measure. Your outcome measure is probably going to be decreasing your VTEs. Your process measures could be increasing your STD compliance, increasing your medications given before surgery, increasing the use of order sets, increasing patients ambulating, increasing the use of active and passive range of motion, or decreasing patients refusing STDs, decreasing your VTE rate. Sorry, I geeked out a little bit on the data, but you get my idea. You're going to be doing lots of different things there, but they're all going to fall under your aim. And one of the things, you don't want data paralysis. You may just want to say, team, for this month, we're just focusing on STD compliance. Next month, we're just focusing on making sure the medication's being given before surgery. And it needs to be the Pareto theory, where you're looking at where is 80% of my problems in 20% of the population. You want to look at those units that are having the most trouble with VTE, and that's where your focus needs to be, and that's where you're going to get your amazing results. So when I talk about right people, you may recognize some of these people on the screen. This is the Trauma Surgical Intermediate Unit at Vidant Medical Center. This is Rebecca Williamson, who is one of my all-star Clot-busters and doing an amazing job on SIU. This is Michelle Tyson. She is my Cardinal rep. For those of you on the line, I would say connect with your rep, partner with them, let them come in and do in-service with you. They know the equipment even better than you do. So that's part of that right people piece. So I want to go and break this down for you even a little bit further. One of the things I really, like I mentioned earlier, you want those strong physician champions that have a great lens. They're the ones that can do drill downs with you and say, you know what, they could have maybe given Lovenox or heparin, or absolutely not. With this spinal procedure, they lose this amount of blood. You would not want to give that. That's outside of my scope, and they're going to be able to help me with that. They're also going to be able to have those. One of the things that I've been able to do with my physician champion is we've had some great lunch and learns. We've sat down with those providers. We've showed them the data. We've showed them how well we're doing with giving the prophylaxis, the chemical prophylaxis, and we've had some of those crucial conversations of, can we do better? What are we doing here? Is there opportunity to give more? So engage providers and surgeons are imperative in your work. A robust unit council, these are your people that are going to be doing your work at 2 in the morning. They're going to be walking around, looking at your compliance, making sure that we're doing this on bedside shift report, that they're going to be looking at all the things to do to prevent VTEs. Now, you might be saying, well, we don't have a unit council. Well, these unit counselors are great, not just for VTEs, but all of your quality work. And it's another place you can kind of sneak in that VTE task force if you're trying to get one started. Go to those units that fall in your top 80% of the problem, present data to them, and ask them to start looking at just looking at the STD controller and looking at your compliance just a couple times a shift. Now, the ladies here that are in turquoise, these are my nursing assistants. Please don't forget them as a resource for you. They are secret weapons. They're in the room a lot. They're doing the baths. They're doing the movement. They're getting them up to the bathroom. They're walking them. Let them be part of your project. And they definitely should be included in your unit council. I said hot huddles because a lot of times you go to huddles and they can be kind of boring. Hot huddles are a great way. You've got everybody in the room to talk about, remember Mr. Smith that threw the clot, that had the PE? Well, unfortunately, when people have clots, they have a 20 or 30% chance to have them again. So some of your hot huddles will be talking about those people that are high risk. They have a chance of having this event occur again, or they're non-compliant. This takes 30 seconds. You've got a captivated audience. Say today, remember Mr. Smith is back with us. Also, when you have time on bedside shift report, or if you have students here today, please try to grab some compliance for me. Check your chart. Make sure we're not refusing. And if you are, let's troubleshoot with the charge nurse and the provider. I don't want to spend a whole lot of time on QI frameworks, but I think it's really important that you have something guiding your work. I'm lean trained. I'm Six Sigma lean trained. All you need to know about lean is really big about eliminating waste. So when you're walking the walk and you're talking to your nurses, if you find that it takes them 45 minutes to order a controller to the floor, or we found that it was difficult for how to document noncompliance, whatever you're finding when you talk to the nurses that are waste, see what you can do. Partner with your equipment experts. Partner with your Cardinal rep. Talk to the people in IT and try to make it easy for the nurses and the providers to do the right thing. What Six Sigma is all about is decreasing variability. When you use order sets, you're going to be standardizing. That means anyone who comes to our organization is all going to be getting the same care. When you go to McDonald's, you don't get an undercooked hamburger. And the reason for that is because they have set it up that hamburger cooks the same temperature every single time. That's the same. It's called the Toyota method. You've probably heard of it that way. But that's all about what Six Sigma is about. And why we've adopted it in the healthcare industry is because we want to decrease variability so then we can improve our outcomes. The last thing I want to talk about that I think is probably the most magical of well, a lot of my stuff's magical, but this is one of my favorites, is the live drill down or the live autopsy. When you have a patient that has a clot, having your cheerleader on the unit or your clot buster let the quality nurse specialist know and management know, and you get to go up to that unit with the nurses taking care of that patient and look at the chart live. It's even greater when you can have the provider. You can catch them around, and you can all have some really great discussion about why did this happen. And it may be that they were wearing their STDs, and maybe they weren't wearing their STDs. They may have been refusing. There may have been issues where something was held. It fell off the MAR. We have just found some really great information. And again, this is where you want to build that psychological safety. This should not feel punitive. You want nurses to participate and providers to participate and give you their honest feedback. Because often as a quality specialist, when I'm looking at the chart after it happened, I'm kind of the armchair quarterback. You want someone who's right there at bedside. So when you come up with your data plan, which is so important when you think about what do you want to look at, I've given you some things to think about. Now I want to talk about that, take that right data thing a little bit further. You want to look at, do they have VTE prophylaxis ordered? You want to look at heparin versus Lovenox. Why? The efficacy of Lovenox is actually higher in the research. So you want to see if there is a trend with you having more heparin. The only reason someone should give heparin is if they have renal insufficiency. So those are things you want to look at is heparin versus Lovenox. Of course, like I've already been talking about and we'll continue to talk about, is are we wearing the STDs? What is our compliance? What is our barrier? And what kind of discharge are these patients getting when they go home? Are they getting discharge instructions? Are we doing a care plan for them? I'll tell you, when Joint Commission came to our hospital, one thing they talked about were our care plans and streamlining them. So we worked on the VTE care plan so it could be simpler. See, when someone has a VTE and they go home with them, the stockings alone are $70, and some of the medication, the DOAGs, the anticoagulants, the oral anticoagulants that they're going to go home on, can cost anywhere from $200 to $500, and sometimes this is after insurance. So those are things you want to be talking about on the preventative side. Post-event, you want to think about what is your reporting structure. How do you find out when you have a PE or DVT on your unit? Can you find out in less than 24 hours? What is your drill down process? Do you have a tool, an Excel sheet, an access? What are you using to collect that data that's meaningful, that's going to tell a story, that's going to change our behaviors to drive our practice? What EHR support do you have, your electronic health record? I have a report built in Epic that pulls all DVTs, all VTEs, DVTs, and PEs. Within that, I can look at present on admission, and I can also look at ones that happened. I can see their admission, their discharge, their BMI, and their discharge unit. Why do I want to know about BMI? Well, you're probably thinking obesity and sleep apnea are risk factors. They are. But what you might not have known is lower BMIs often don't do as well as people that have higher BMIs. And the reason for that is people with higher BMIs have gotten used to a state of hypoxia, and they sometimes have better outcomes. So that's another interesting thing, another variable you can look at. Having a data repository like Vizient or Premier, these are excellent ways to go in and look at different variables. For example, you can look at your post-operative VTE, your PSI-12, patients with COVID greater than 65 that ended up on a ventilator. What's the connection with that? Is because we know that patients that are ventilated have stasis and they have a lot higher chance of having an event occur. So the next thing, and this is kind of for my quality geeks on the line, talking about Dartmouth method, when you think about starting at a unit level and a micro system and all the way up to your macro system. When you're meeting and you're talking with your stakeholders and you're thinking about your key performance indicators, your KPIs, one of the things I would talk about is VTE rate. Why? Because VTE rate is going to tell me Did my numbers truly go down because we changed the process, or did we decrease the number of people that we have? Did we have our unit numbers go down, and that's the reason now we have less VTEs? You want to look at your readmissions. Is the reason we have readmissions because we have a problem with what I mentioned earlier, they can't afford the medication? Is it because we know that people that have VTEs have a 20 to 30% chance of having them again? I would look at length of stay. The good news is, as you decrease your VTEs, your length of stay is going to go down and your mortality is going down. Now, when we talk about VTEs, it is a correlation. It's not a causation. It's extremely hard to say this PE caused this to happen. Now, if the person's had surgery, they just gotten up on the unit, all of a sudden they code on you, most probably they have done, especially if they've had an autopsy, they've had a PE and that's what's caused it. The other thing you want to look at is transfers to the ICU or bounce backs. Those are great. These are all metrics that you can show as outcome measures that are coming down. And one of the biggest things you're going to be able to show is cost. A VTE in different organizations, but they run between 10 to 90,000 depending on how their length of stay is. So when you start decreasing these numbers, and you will, you're going to see these things go down. So the last piece I kind of want to wrap up with is just how do we get this, talking about creative solutions, clot busting, and I love saying going beyond the squeeze. So before we get into that, I'm going to take 30 seconds, 40 seconds, and I want to hear a little bit from you. What is most needed to improve your VTE prevention protocol? All right, I'm going to give you about 10 more seconds. Again, this is for me to hear from you, not to quiz you. There'll be a long test at the end. I'm just kidding. Okay, institutional support, leadership. Yeah, having trouble with those patients that are not adherent, reliable data and performance tracking, and other. Awesome. Very good. Thank you for participating. So, let's see. Okay. So let's talk about creative solutions. And some of you, this is going to come really natural. I joke. I feel like some of my nurses are kindergarten teachers in a nurse's body. They just do great bulletin boards. They have fun activities, and I'm always kind of tapping into them. Using a communication board to track when the person is getting up. And I just want to put in a little caveat with that. Ambulating to the bathroom is not going to be enough for your patients. They have got to be getting up more and moving more, not just doing a pivot to the chair. So we want to use our whiteboards, bedside shift report, talk about the goals for the day. We want to be wearing our STDs 22 to 24 hours. We really want them on all the time, taking them off for baths and to check skin integrity. But after that, if the physician's ordered them, it is a doctor's order and they need to stay on. But using the whiteboards, communicating, putting little boxes up there that you can check throughout the day when they walk. Star walks, this is when the patient gets up and they walk up to the secretary or they walk to some point and they get some type of tangible thing, whether it's a little star, a bead, something where they can collect, and when the nurse comes in, they can say, hey, look, I've gotten all these stars. It's a wonderful way. Our secretaries are such great greeters and great communicators, and they usually enjoy this process too. They develop that relationship When they see Mr. Smith who got up, he had the PE before, but he's come back to the unit, so we're going to keep him up and moving, and they tell him what a great job he's doing, they give him a star. That's just fun. The other thing units have done, I've seen them use magnets. This is for their hourly rounding, and in their hourly rounding, they've checked VTE prophylaxis and made sure the STDs were on, the controller was working and tracking compliance, and that they were also getting their VTE prophylaxis. Having friendly competitions, I know there are times we've got to hold each other accountable, but I think in the beginning we want all of our quality things to seem fun. It's like when you're trying to get your child to clean their room, you want to do something fun with them, give them a positive reinforcement. We've done things before. We've done pizza. We've done food competitions. A lot of times we let both shifts win, but we'll say, okay, nights versus days, let's see who can have the best compliance, and then they get a pizza party or they get candy. And these are great things to keep you going. Now, you're going to have to build sustainability in your processes. A lot of times when you first start these things, we'll do great, and then another party will come in and we'll shift. So you've got everything you do in quality, VTE work, any of these things you're rolling out, you always want to think in the forefront of what are my sustainable things, including your families, especially in the ICU. If you have someone with a brain injury, autism, dementia, something where they don't tolerate the STDs well, and you can have the family members involved that can help the patient do passive, active range of motion, get them to tap the footboard, dance, move their legs around. Duke University is actually doing a trial right now, and I think in their ICUs where they're using bikes. And I don't know if anybody is on the line from Duke, but they actually use stationary bikes in the ICU for these patients who do not tolerate the STDs. So you just want to think outside of the box, and you're like, Amy, I'm just not sure what I need to be doing or where to start. How do you prevent stasis? How do you keep the blood flowing to the leg? And just think about that. How do I prevent that hypocoagulability and that endothelial injury? Moving is grooving. All of our quality things that we do can be prevented if we could just get the patients up and walking. So clot-busting, this is what I call all of my champions out there, and I know some are on the line from Vidant Medical Center and Vidant Health. They do a wonderful job of tracking their data, running reports, looking to see who actually had VTE prophylaxis ordered, and are we doing what the physician has ordered. Now, I want to take a moment and show you something. I've been a nurse for 22 years, and until I started really working with Michelle, I did not know, and Michelle's Tyson's my awesome Cardinal rep. When you look at this, when you see this arrow right here I'm pointing out on the screen, you can look at compliance on your controllers. So what we've been doing on the units is saying when you come in, check your compliance and bedside shift report and call the question of why have they only been on 8 out of 12 hours. Now this particular meter, when you hit A down here, is set for 24. We're teaching our people to do it 12 and then to hit B and reset it. And you can't see this right here on this screen, but when you look at the screen, you should see a little icon with a person, and that lets you know that you have this capability. If you do not have this capability in your controller, you need to be reaching out to your biomed and your Cardinal rep and doing in-services and really using these controllers to their capability. We've come a long way in STDs. They're now more cooling, they're easier to wear, and now we're actually being able to track compliance on them. So when I talk about Clot-busters, and I digressed a little bit because I got excited about the controller, how do you recruit a nursing workforce that is very overworked right now, very tired, they've been through a pandemic, most of them been flexed up? You recruit them because you're going to be fun, you're walking around, you've got candy, you're pulling them in, and you're going to make it easy for them. When I recruit people, I pretty much say, I just need you with me. I need street cred on your unit. I need you to walk with me, introduce me to people, and I make it as easy as I can for them. I also try to target my nursing students or my master's students or a PhD student, someone who needs a project or a publication. That's a great way to recruit. I've gotten away from the traditional, like in-services and long meetings, I do much better with just going pod to pod or going around hallway to hallway, having a Roman cart, and letting that Clotbuster go with me, where they only have to have a time commitment or 10 to 15 minutes. I offer them WebEx options to meet with me, and I try to meet with them when they are working, where it's not a huge time commitment, and I definitely never ever want them working on their days off. I say all hands on deck because my Clotbusters can be anybody. They can be nursing students who need something to do. They're standing up in the nurse's station. I ask them, I show them how to do this on the controller, and I get them to walk around with me and look at whether the STDs are on. You can use your secretaries, your care partners, housekeeping. Everyone can look to see if these STDs are being worn or not. Using an easy auditing tool, just print out something that's really easy to collect data on and have a centralized person they turn it into, and then you let your quality person put them in a tool or an Excel sheet or something where you can get graphs and data out that then you can report to your executive. And then one of the things, like I mentioned earlier, we've been using this compliance exercise during bedside shift report, and it's working out awesome. They go in, they do bedside shift report, they hit the buttons, they check compliance, and they call the question, did Mr. Smith get his Lovenox today? And Mr. Smith is laying right there. So if he says no, now he's got two nurses to talk to him about the importance of getting that compliance, getting that medicine to be compliant. So the last thing I want to kind of wrap up with is how do we go beyond the squeeze? Mechanical prophylaxis is awesome. It is wonderful. And it does great things for our patients, especially the ones that can't tolerate the chemical prophylaxis. Having the chemical prophylaxis and the mechanical prophylaxis, that's what's in the research. That shows us that is going to be the best coverage for our patients. Order sets, order sets, order sets. When you think about sustainability and a system-wide approach, order sets are going to be the best way to go. In your order sets, you can put Lovenox before heparin. You can put your Caprini risk assessment tool in there. You can embed things to make it easy for the provider to assess their patient, do risk stratification, and order the right thing for the patient. We've added in our order set an alternative order set for VTE, and it includes the STDs, but also includes ambulating and doing, getting the patient up and moving them and doing active and passive range of motion. I love my case studies. My Mr. Smith one was very simple, but I think doing a case studies and telling stories at your meetings, at your executive meetings, and your unit councils, anytime you're in front of people and you can make it personable and you can tell all about Mr. Smith and his grandchildren and the birthday he missed and all these things, that makes it's emotional. It's that Aristotle when he talks about when you're doing persuasive speech and you're making that emotional appeal. That's given a case study at the beginning of whether it's in front of your executives or your task force, that's really important. I love simulation. Doing a PE simulation is great for new grads, and it's even great for travelers, it's great for all of us. When you walk in a room and you see someone who's in respiratory distress, you want to start kind of peeling back the layers of the onion and go, wait a minute, they're post-operative, they've not been wearing their STDs, and we held their Lovenox today, and now they're desatting. Because there are times you want to go down a cardiac highway when it might be a respiratory issue or pulmonary embolism. There are nursing risk assessment tools out there. We do not use them currently at Vidant Health, but I do think they are good things to have. I also think having nursing protocols in place. We have one where if the nurses feel the patient needs STDs, they can go ahead and order the STDs. They're not waiting for the physician to do that. So that is it for me, and I ended almost 45 seconds early, so we have plenty of time for questions. So I'm going to open it up for questions now. And thank y'all so much. Thank you to Cardinal Health for this opportunity, for Vidant Health, and everything y'all have done here for us to be successful.
Wonderful. Well, thank you, Dr. Campbell, for such an engaging presentation today. We'll now kick off today's Q&A session. Audience members, you can submit any questions you have for Dr. Campbell by typing them into the Q&A chat box you see on your webinar console. We've already had a lot of great questions rolling in, so let's jump right in. The first question is from an audience member who is asking, does your organization have an STD for every patient room, and what are your thoughts on STDs versus TED hose?
That's a great question. We do not. We really encourage the physicians to do, because not everyone needs STDs. We want the patients, the walkie-talkies, to be up moving and walking, because that's so much better for them. And it even prevents falls. We often think if we get someone up a lot, they're going to fall, and it's the exact opposite. The more they're moving, the less chance they have to fall. So we do not. We try to have PAR levels on every unit, so we know on these particular surgical units, if there's 40 patients, we usually need 30 machines up there. We also try to have 2 or 3 extra somewhere on the unit, so if we come into a situation where we're having trouble getting a machine, we've got those to fall back on. In transparency, we've had issues before. We might have gone a couple hours without a STD machine, and then we've had to go to the unit and say, okay, how did this happen? So we at our current organization, I don't personally think you need STDs in every single unit. I do think there's a way to make a lot of money by making a bed that already has STDs in them, but that's a whole other story. I think what the literature is saying, now TED hose help to promote venous return, the way the STDs are going to work, the way they do the compression, and you've got it at 3 different points on the leg. The STDs have a better efficacy, but if you have someone who cannot tolerate the STDs, then trying to troubleshoot with a foot pump or TED hose, I think is great, but make sure when you're doing this, you're having those conversations with the provider and they're on board with whatever switch we're having. I always tell people don't call that surgeon at 2 in the morning to tell them you switched to foot pumps, but make sure they know they're not using the prophylaxis or you've made a change. But it's always better than them not having anything at all. Great question.
Absolutely. Thanks for clarifying that, Dr. Campbell. The next question is, for VTE prevention in your facility, do you use both pharmacologic and mechanical prophylaxis in appropriate patients, and is it different in surgical versus medication patient populations?
Yes, we try to use, in our patients that meet the risk assessment tool, we try, or meet the risk, we try to put them on Lovenox and STDs. There's not any difference. The only thing we look at in our surgical patients is we make sure that they get that Lovenox or that anticoagulant before they have surgery. That's real important. And that's basically because they're getting ready to have a lot of things that are going to happen within their body that, and they may be giving them things during the surgery that's going to promote clotting. So that's one of the reasons to give the thing. And they're also going to be laying there. Some of these surgeries might be 6, 8, 9 hours. So there's a lot of different reasons you want to make sure you have that anticoagulation on board before the surgery.
That makes a lot of sense. Thank you for weighing in there. We have another audience member asking, are STDs primarily about mitigating legal risk? What does research indicate in terms of efficacy for VTE management?
What the research is telling us is absolutely chemical prophylaxis is the best thing to do. When you have STDs on, now you've got 2 things working for you. One of the things we really try to, or I've seen, and we even see it in our own practice, I'll see nurses say, well, Amy, I have a heparin drip. Why do I need to keep the STDs on? Because when that heparin drip stops, or we have to, because they've developed HIT, which is heparin-induced thrombocytopenia, or for whatever reason we take the chemical prophylaxis off, we need to make sure we have those STDs in place. So yes, as far as mitigating risk, you want to have both things on board. And research shows, 2 is going to be better than 1.
Absolutely. Thank you again, Dr. Campbell.
One of the things I'll say to you about resources, the CHEST guidelines from AHRQ, the Agency for Healthcare and Quality, they are a wonderful place to look for the latest things out there, and I always go back to my CHEST guidelines. There's also a lot of great articles if you just in your free time, you want to look on Google Scholar and things. The VTE research is difficult because we don't know who's going to throw the clot, right? A lot of times we're looking at patients afterwards. it would be great, you know, sometimes if you knew these people are going to be so high risk, they'll be part of the research study, and we know that, you know, we can project them a little bit better. But the research is a little bit harder because of that.
That's a great point, yeah. We have a question here about the use with EPIC, and the audience member is asking, on your report in EPIC, what is being pulled? Is it concurrent coding? Are there radiologic reports? Can you talk a little bit more about that?
Yeah, great question. It's AHRQ's codes. It's all the I-180s and the I-26 numbers, and we use those codes. It's after discharge. So what will happen is I will go into that report and I'll run it, and I'll either do present on admission. Most of the time I'm looking for the ones that are not present on admission. I look at a couple weeks at a time, or I'll look at a week. Then what I have to do is go into each one of those VTEs to make sure they were not less than 48 or 24 hours, that they weren't present on admission, and they truly did have an event occur. AHRQ does have some exclusions. Most are dealing with spine and brain injury. So you want to look at that. And if you're looking at your PSI-12, which is your postoperative, obviously you want to make sure they have had a procedure done for them to fall into that PSI-12 bucket. So we look at the AHRQ codes. That's how it's pulled. And then from there, I can see the patient's name, their HAR number, so I can go into the chart. I get their admission, discharge, and their BMI and what unit they came from. Oh, and if they expired or not.
Very helpful to know. Thank you for clarifying that. We have another interesting question here, which is, how do you address nursing noncompliance with applying STDs?
Well, I think the first thing you want to know, and one of the things I didn't mention that's so important, I believe nurses will do anything, and providers, if they understand the why. So the first thing you want to kind of go in with the approach of, tell me a little bit about the STD machine. Are we having trouble with it not working? Is it beeping a lot? Are you having trouble with this patient? Is it making them more combative? You want to approach it from that angle as to, Amy, why isn't your patient doing what they're supposed to do? You don't want to come across as punitive in any way. And so I think you first, and most of the time when I talk to the nurses, they'll say, well, you know, Amy, it keeps beeping off. And I'm like, okay, let's look at it. Well, it's showing you've got a foot and a leg. And a lot of times when it's doing that, it's because there's a crack in the tubing. Let's replace the tubing, and let's come back and troubleshoot this together. And now we've got the pump working, you know, or see if that's what the issue is. And as far as family members go and patients go, I always try to go in and talk to them and say, you know what, you've been through so much. You've just survived this awful car crash or this really long surgery. I mean, nobody wants to be in the hospital, right? And so you're doing so amazing. Now I need you to continue to do amazing and keep your STDs on. And I know you don't want to wear them, but right now your physician's ordered them because if you don't wear them, you're going to get a clot in your leg that's going to prolong your stay, and it's going to hurt. And worse, it can go to your lung, it can keep you from breathing, and you can actually code and not go home from here. And I usually have that real blunt conversation with them, but that helps to wear it. But I think answering the question from Diane is just making sure you've troubleshooted to make sure we're making it easy to do the right thing. The machine is working correctly. They have on the cooling sleeves that it's not compressing at one part and not compressing at the other. And worst case scenario, let's explore alternatives. Can they walk 3 times a day? Can they do foot pumps? Can they do TED hose? Anything beyond just not doing something.
Wonderful. Thank you for clarifying that, Dr. Campbell. The next question is, does your order set have an oral option for VTE prophylaxis in non-surgical medical patients?
Yes. In fact, we just added rivaroxaban to our order set, and this was a really great initiative that was part of Dr. Manning's work with some of his residents. And they brought in some research to our Clinical Excellence Committee. And I didn't mention, but I also work really closely with our Anticoagulation Committee. And we went before them and we talked about the different medications, and we added on an oral. And the great thing about adding on an oral to your order set is grandma who doesn't want to get shots. Well, heck, Amy doesn't want to get shots in her stomach twice a day or 3 times a day. We'd much rather take a pill. So rivaroxaban, I mean, there are definitely alternatives to use for someone who doesn't want to take the Lovenox in their stomach.
Great. Thank you again, Dr. Campbell. And we have another question here about missed doses. Do you track missed doses, whether they're refusals or for other reasons? And is there a standard process for communicating with the provider when a dose is missed?
Great question. What we look at is, unfortunately, most of the time when I'm tracking the ones that were missed, it is after an event has occurred, and a lot of times that physician has not always been notified. And so that's something that puts us in a pickle when it's like, well, it looks like they refused their STDs for 3 days, which is probably it's documentation, or it doesn't look like the nurse provided education, and it doesn't look like the provider was informed that they were refusing medication. So that's just something that we want to follow up with. Pharmacy does track, in our organization, pharmacy does track held meds. Now, I do know that in one of my Clotbusters, I'm not sure she's on the line, Stacy Simmons at Roanoke Chowan, who does an amazing job. She runs a report every day, and if you're in Epic, what she does is she runs a report for patients that have VTE prophylaxis ordered, and then she goes through each one of those patients and looks to see if they got their VTE prophylaxis for that day. She walks around and she talks to the patients, and when I'm doing unit focus work like we are on SIU right now, TSIU, that's one of the things we're going to do. We're going in layers, but that's one of our layers is looking to see when those medications were held and doing the follow-up. So to answer your other question, I'm currently working on with a DNP student, and we're looking on an algorithm to follow for prophylaxis on held versus not held and what to do.
Good to know. Thank you, Dr. Campbell. Looks like we have time for a few more questions. The next is, can you still put a patient on STDs if they have a history of DVT?
Yes. The only reason I would, of course I would discuss it with my provider, and I'm really glad they asked this question because I see this a lot too. Remember, the STDs can work on one leg. So if you have a patient that's had a graft done, or they've had a bad trauma, or they've had an injury, a burn, a decubitus, whatever, don't not just do the STDs because they still can have something done on the other leg. I know that may be a little bit aggravating for them because now they've got something squeezing on their good leg, but it keeps us from not having any prophylaxis, prophylaxis on board. So, and I'm not sure, repeat the question, I'm not sure I think I missed a piece of it.
Sure. The question was, can you still put a patient on STDs if they have a history of DVT?
Yes. So I want to make sure I got the piece. So yes, as long as it's, I would obviously talk to your physician. If they have a DVT in that leg, we do not want to put an STD on it because then it could possibly cause it to break off and cause a PE. But if they have a history, like they're just coming in with a history, and usually when someone comes in with a history, we scan them and make sure they don't have a DVT, and then we put the STDs on them. So it'll be a provider discretion, but I think it's an excellent question to say, hey, Dr. Campbell, did you realize that they have a history of STDs? Are we going to STDs, of DVTs? Are we going to scan them, and what's the process?
For sure. Thanks for weighing in on that one. And then on the other end of the spectrum, we have a question about, do you conduct VTE risk assessment at discharge?
We do not do what we'll do is look to see, mainly what we look, when we do their discharge instructions, we look at their other medications, and we kind of look, okay, for example, you're diabetic, you've got obesity, you've got sleep apnea, high blood pressure, all these things are going to make you at risk for clots. And so that'll be something, if they were my patient and they were post-operative, I would be saying, make sure that you're up, that you're moving. I'd be telling the family members, you don't want them to go home and just sleep and lay on the couch for a couple of days. We want to make sure they're up, they're moving, and they're grooving.
Wonderful. Well, that is all the time that we have left for today. Dr. Campbell, thank you again for such an excellent presentation, and thank you to Cardinal Health for sponsoring today's webinar. To learn more about the content presented today, please check out the resources section on your webinar console and be sure to fill out that post-webinar survey. Thank you all so much for joining us, and we hope you have a wonderful rest of your afternoon.
Thank you, everyone.